Hi, I'm Dr. Howard Jack West, and I'm a medical oncologist with a particular focus on thoracic oncology. I'm an associate clinical professor in the medical oncology division at City of Hope, and I also lead a program called Access Hope that works on remote consult services there. And I'm based in the Los Angeles area. I'm happy to welcome all of you to this multidisciplinary tumor board on a series of provocative lung cancer cases.
Hi, I'm Michelle Ginsberg, and I'm a director of cardiothoracic imaging at Memorial Sloan Kettering Cancer Center. And I'm also vice chair for education in the Department of Radiology, also at Memorial Sloan Kettering. And I'm also a professor of radiology at Weill Cornell Medical College, which is across the street from Sloan Kettering in New York City.
Hi, everyone. I'm Suresh Ramalingam. I'm a professor of hematology and oncology at Emory University and the Winship Cancer Institute. Like Dr. West, my focus is also on thoracic oncology.
Hi, I'm Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of Thoracic Surgery at Emory University in Atlanta, Georgia.
Hi, everybody. My name is Cliff Robinson. I'm a professor of radiation oncology at Washington University in St. Louis, and I am the chief of the Cardiothoracic Radiation Oncology Service and director of clinical trials.
Adenocarcinoma, a 69-year-old smoker, 40 pack years, hypertension, tobacco and alcohol use, and a progressing right shoulder pain and cough, 7.8 centimeter right apical lung mass encasing the SVC and invading the right brachial plexus. Pathology is consistent with poorly differentiated carcinoma and sarcomatoid features. Staging PET-CT and brain MRI shows no distant metastases, and the staging based on what the imaging available is T4N0M0. He has right shoulder pain, cough, fatigue, and weight loss. His performance status is 2, and his past medical history we've gone over. What would be recommended? We have imaging as shown here, Dr. Ginsberg.
So we see that this is a large mass measuring 7.8 by 6.5 centimeters in the right upper lobe. And it does extend into the mediastinum with loss of all fat plates to the vessels. So probably involvement of the right brachiocephalic. It does touch the trachea with some mass effect on it, and extends even more superiorly, almost like a Pancoast tumor. We do see that there's central necrosis within this mass. On the PET-CT, there's loss of avidity centrally, which means that, and we see that also on the CT where it's lower, darker in density. So some of this is necrosis too. In addition, this patient has very severe emphysema with a large bullae, just even in that right upper lobe, you see adjacent large bullae, and also contralaterally, a lot of emphysema. The PET-CT did not reveal additional sites of disease, but this is essentially a large mass which is invading into the mediastinum and superiorly into the supraclavicular fossa, and presumably also brachial plexus, may be based on some of the symptoms as well. The SUV was 17.9.
Right. So we've looked at the imaging. We have a biopsy showing a poorly differentiated carcinoma with sarcomatoid features, a low PDL1 in the 1 to 50, and we don't have characterization beyond that, STK11 positivity, and no driver mutation seen. Dr. Force, what say you about the role of surgery here?
This does not appear to be surgically resectable due to the involvement of the great vessels in the brachial plexus, so it appears to be unresectable. I do think he would require mediastinal staging because even though none of the lymph nodes lit up with a tumor that size and a central lesion, there's a high chance for microscopic metastatic disease, but he would not be a surgical candidate to remove that. It's not resectable.
Cliff, what would you say? How critical is it to have mediastinal staging just if we're planning a chemoradiation approach anyway? Is it going to change any of the management, or is it just for prognosis? And is chemoradiation the platform that you would favor here?
Yeah, I mean, going back to the issue of surgery, I would absolutely ask the surgeon first, because these lesions generally do very poorly. This is a big mass. It's highly invasive. The sarcomatoid component portends a horrible prognosis in that regard. And this is frankly a very morbid place to progress. These patients often have considerable pain and morbidity from it. And so anything we can do to minimize that. As it relates to the surgical staging, if that's an option that's available to the patient, I think it's always better. We do not electively treat lymph nodes anymore. So if I treat the primary, I do not in 2021 electively treat the rest of the mediastinum. We only treat areas that are known to have disease. So if we do not have that information because it's missing on the PET scan, then that puts us at a disadvantage. So if it's possible, and we find that they have lymph node positive disease in the subcranial space or the paratracheal lymph nodes, then we would target that with the full doses of radiotherapy.
Okay. Ram, what are your thoughts about chemoradiation and basically the Pacific platform here? Sarcomatoid, there are certainly many reports that they can respond better to immunotherapy than anything else. That may be damning with faint praise, but he also has an STK11 mutation that's not favorable. How do you put all this together?
Yeah, I mean, I think we know that sarcomatoid patients tend to do less well from a systemic chemotherapy standpoint compared to the typical adeno or squamous population. And we also heard from Cliff in the situation that radiation approach for this patient is not likely to have as good outcomes as we would see. So overall, to me, this is a situation where there are a lot of unfavorable factors that are in play here. Certainly, the PD-L1 expression being in the 1 to 50% range is a good thing. Not that we use that for deciding whether patients should get durva or not, but the STK11 mutation does somewhat give me the lower the enthusiasm that I have in expecting that he's going to have great outcomes with durva. So this is a patient that I might say chemo RT, particularly using cisplatin-etoposide kind of chemotherapy, might be a little more favorable from my standpoint. So you do what you can to be as aggressive as possible with the chemo RT phase. And then I would still give durvalumab in this situation. I wouldn't stop it. But in my own mind, I'm thinking that the outcomes are not going to be that great, unfortunately.
So I will just summarize, and I think we do have as close to a consensus as you could hope in a case with so much going on. This gentleman has an unfortunate cancer with a lot of negative prognostic factors associated with it, but we are really of a generally like mind that this is not a case that is strong for surgery. Chemoradiation is likely to be an optimal approach, and we would prefer to get mediastinal staging just to clarify and potentially refine the radiation field. Knowing that sarcomatoid cancers tend to not respond well to systemic therapy, a cisplatin-etoposide concurrent RT approach would be what we recommend, with an intent to follow that with durvalumab along the lines of the Pacific trial, knowing that sarcomatoid cancers can respond very well to durvalumab. The positive finding of at least some PD-L1 expression is favorable, but the STK11 mutation less so. Still, we need to go ahead with the most aggressive approach that makes sense and hope for the best. Okay.
The one suggestion I would have is, because of the sarcomatoid, for down the road purposes, to have NGS done to see if the patient has a MET exon 14 mutation. So that could be another option a bit down the road.
Okay. And one other thing to note is that because of the sarcomatoid cancer, in the setting of more advanced disease, if it does progress, it would be particularly relevant to do broader molecular testing, such as with an NGS platform, looking for a MET exon 14 mutation.